All right, welcome to The Explainer. Today, we're diving into a diagnosis you absolutely cannot afford to miss: enteric fever. We're going to break down what it is, how it really shows up in your patients today, and most importantly, how to lock in that diagnosis.
Okay, let's start with a classic. Picture this, because you will see this case. A young, otherwise healthy person, just back from a trip. Now they've got a fever that just won't break, and their stomach is bothering them. I mean, the list of possibilities, it's a mile long, right? But there's one thing that has to shoot right to the top of your list.
So where do we even begin with that differential? Well, with a story like this, there's a really clear and crucial first step in building your case. And here it is, your first major clue. A fever that's been hanging around for more than 3 days, plus travel to an endemic area like South Asia. That combination alone, that's your trigger. That's what should make you think enteric fever and get the ball rolling on a workup.
Okay, so we've got a strong suspicion. But what exactly are we dealing with here? What's the culprit? Let's meet the suspects, microbiologically speaking.
So enteric fever is actually an umbrella term. It covers this severe systemic illness caused by invasive salmonella, and we're specifically talking about serotypes typhi and paratyphi. And get this is fascinating and so important. Humans are the only known reservoir. Think about what that means. Every single case gets passed somehow from one person to another.
Now, from a patient's bedside, you really can't tell these two apart, but there are some key differences under the hood, as typhi is often linked to contaminated water, while paratyphi is more commonly a foodborne issue. But here's the part that can really trip you up in the clinic. The standard typhoid vaccine is totally ineffective against paratyphi. So a traveler who did everything right, got their shots, they can still walk into your ER with full-blown enteric fever. That's a huge clinical pearl right there.
All right, so we know the bug, but what does the patient actually look like? And this is where the textbook stuff you cram for your boards can actually lead you astray.
Yeah, we've all seen this timeline, right? The classic untreated case from the history books. Week 1 has that stepwise fever. Week 2 brings on the bad abdominal pain and maybe some rose spots. And by week 3, you're looking at terrifying complications like your bowel perforating. It's a good framework to know, but remember, this is from 100 years ago, from the pre-antibiotic era.
And that right there is the whole point. Because we're pretty good at giving antibiotics early now, that classic picture is basically gone. If you're waiting for that textbook progression to unfold, you are going to miss this diagnosis. What you'll see today is much vaguer. You get fever and chills, sure. Abdominal pain, okay. But look at this. Headache is incredibly common. You could have diarrhea or constipation. It's basically a coin flip. And a cough? A cough in almost half of your patients? Wow. How easy would it be to misdiagnose that as a simple respiratory infection? And those famous rose spots, the pathognomonic sign everyone looks for? Forget about them. They're practically a myth now. We see them in less than 1.5% of cases. So if you're holding out for a rash to make the diagnosis, you're almost guaranteed to miss it every single time.
So if the symptoms are so nonspecific and the classic signs are gone, how in the world do we actually prove it? How do we go from suspicion to certainty? Let's walk through the actual steps.
It's really a 3-step dance. Step 1, it all starts with you, with your clinical suspicion, and that is driven by that travel history. Step 2, you got to get cultures. Blood culture is the big one. And listen, you have to send a good amount of blood to give the lab the best shot at finding it. And step 3, and this is important, you have to think about starting treatment before you even have the results back, because the complications can be really serious.
And this chart, it shows you just how tough that can be. Yeah, bone marrow culture is the best, over 90% sensitive, but we're not doing that routinely. Our go-to, the blood culture, is only positive about half the time. So let me say that again because it's critical. A single negative blood culture does not rule out enteric fever if the story fits. You can't stop there.
And let's have a quick word on what not to do. Do not order a Widal test. Just don't. It's an old test, it's not specific, and a positive result might just mean they had a past infection or a vaccination. It's going to confuse the picture, not clarify it.
And I know what you're thinking. What about all the new rapid tests? Well, we all wish they were better, but for right now, they just aren't accurate enough to rely on for a diagnosis. The blood culture is still our gold standard, period. Okay, so let's pull the lens back a bit. We've been focused on our one patient, but to really get a handle on enteric fever, you have to understand the bigger global picture. You have to ask, why is this disease still around? So in a country like the United States, look at this. More than 80% of cases are travel-related, just like our patient. This is why asking, where have you been, isn't just a routine question. It is probably the single most important question you can ask.
So why does it persist in endemic areas? It really boils down to this incredible phenomenon, the chronic carrier. Think about this. A small number of people, maybe up to 6%, they get better, they feel fine, but they just keep shedding the bacteria in their stool or urine for more than a year. Wild, right?
And of course, you can't talk about carriers without talking about the most famous one of all, Typhoid Mary. She was a cook, felt perfectly healthy, but was unknowingly spreading the disease to dozens of people wherever she worked. These asymptomatic carriers, they are the hidden human reservoir that keeps this whole cycle going. And that brings us to our final, and frankly, pretty sobering thought. We are now seeing the rise of something called XDR sci-fi, that's extensively drug-resistant. These are strains that are resistant to nearly all of our common oral antibiotics. So as this terrifying threat continues to grow, it really forces all of us to ask a tough question. How are we going to manage this ancient disease when our modern medicines just don't work anymore?